The first talk should be a kind of talk to let you wake up. And good morning also everybody online. So I'm going to speak on the potential, So it's not a true talk. I put some data and some ideas together to introduce the 2 days. And if we look at why we are sitting here for 2 days to work on the fetal heart, we should keep in mind that congenital heart anomalies are common. If you look at statistics from different countries, you will find always numbers between 5, 8, 8.5, 9, 7, and 10 out of 1,000 births. But all people, when they write such articles, they say what is known is that critical cardiac anomalies are always stable. That means we have always around 3 to 4 out of 1,000 severe cardiac anomalies. The other one, let's say in general, depend on what was included in the study. Was the left superior vena cava superior part of the abnormality, or in recent studies done in Germany, you will see we have a muscular VST because the murmur will be sent to a cardiologist and they will do color Doppler and they see the small VST. So this is why some numbers of the mild anomalies may lead to an increase in CHT, but the true numbers are the critical one, and this is why what we are focusing on the critical anomalies. So keep in mind 4 out of 1,000, and for the one doing nuclear screening, 4 out of 1,000 means 1 out of 250. So as soon as the lady is younger than 35 years old, the risk of having trisomy 21 and the risk of having cardiac anomaly is almost similar. And if you see a lady with 25 years old, the risk of having a thickened nuchal due to a cardiac defect could be higher than the risk of having Down syndrome. So keep this also in mind. It's not only about trisomy 21. And keep in mind also that depending on the study was performed, 10 to 20% are associated with cardiac anomalies. And in the Baltimore, Washington study, 15 to 20% were reported to die in the first year of life, some also due to the associated cardiac anomalies. But I think in the meantime, we have better results in surgery and in some places where severe anomalies of the heart may be decided to be terminated, we have a better outcome than to say 15% will die, I hope at least. And what we also have is we know that heart anomalies are detectable in utero. We know that if you detect cardiac anomaly, you will improve the outcome. And sometimes I say, even if 1 day before birth, you know it's a cardiac defect, you can do a lot for this child. And the most anomalies are still missed all over the world on ultrasound. And the pro of cardiac anomalies is that the acceptance of the parents is big and large in comparison to other severe anomaly in the fetus. So in general, if you want to discuss with your, let's say, authorities to give you money for screening, focus on cardiac anomalies, because this is something where it's always a positive information compared to if you want to have a screening for Down syndrome or spina bifida, they assume it's only about termination pregnancy in many places. So, and this is what we want to emphasize, that there is a screening done on every woman all over the world, and why not to use this screening in order to improve detection of cardiac anomalies. This is one of the many studies, one meta-analysis showing that the detection of cardiac anomaly improves outcome. And this is known, and we know it is known. We know it should be there, but for years there were no data, and in the meantime we have a lot of papers. What are the screening strategies? When I started doing ultrasound in the 80s, there were 3 people I looked at how they are working. Greg DeVore is not here because it's more kind of one-person work. It was Lindsay Allen and Laurent Fermont. Both are pediatric cardiologists, both had retired, and both had 2 different visions or strategies. Lindsay said, I will train the sonographer to do the scan, to have the 4-chamber view, but please, high-risk cases will be sent to the pediatric cardiologist. Laurent Fermont in France said, well, in other words, most cardiac anomalies, they have no a priori risk, And the best way to detect them is I will train obstetricians to learn how to get the four-chamber view on a routine basis. I will train them how to get the great vessels later on, and both did the way. In the meantime, we had a lot of studies. This is one of the slides. I could show you 3 other slides. And I say sometimes sarcastically that this slide is important because if you are writing, let's say, to support a colleague who missed a cardiac anomaly, you can say there are studies showing 5% detection rate and other studies showing 90% detection rate. Why are we expecting to have always a high rate of detection? But the difference in these studies depend always on how the study was set. And if you see the results of what in the UK happened, and this was published in the Lancet in the 90s, you see here that in the southeast region of London, there is a higher detection rate. In general, the univentricular heart and hypoplastic left heart detected in 2/3 of the cases, and transposition only in 3% of the cases. So why? Because, of course, we are expecting with screening strategies A to detect an anomaly not detectable in this four-chamber view. So this is why it is, by definition, not possible to detect a transposition. So in other words, this is one approach, and this is what was adapted many places in the world. And if you look at Germany, this is a study done by pediatric cardiologists focusing mainly on outcome and on incidents. And by the way, they asked the parents how many of the cases were detected in utero, and 12% told them that this cardiac anomaly was known. So we checked, and this is why it's interesting to have 1%. And they wrote in the paper, it's not so high because it's more common in the meantime, but because we included also small VSTs detected in the first years of life because of color Doppler. So, but interestingly, you have 12%, and you have similar data like in the UK, 68% univentricular heart, 60% of Epstein. Interestingly, we have in Germany different regions, and the different lenders, they have different policies. So in Berlin, we have very good detection rate because we have very good people, and the normal doctors send us almost all the patients for screening, and we do the screening for them, and we have detection of many anomalies. So this is why I can offer you many anomalies. On the other hand, other places say it's destiny. Oh, I never assumed that you are only 21 years old and the child has such a severe condition, and unfortunately the child died. I'm sorry, but next time I'll send you to an expert. But next time, rarely there are recurrence cases. So look at the French. The French did another work. In the early 90s, they said, now it's time to move to the great vessels, and they started to include the transposition detection in the 90s, and you see here an increase to from 12% to 48%, and in the year 2000 they have 3 out of 4 cases of transposition detected, and in the Paris region they have more than 90%. So it is feasible. It depends only on what and how you establish your screening. I'm speaking to you here and online because I know you are the expert, the one who may be teaching also your colleagues, the one who may work on screening policies, and this is important today to keep in mind. So you see here what happened also in other places. This is from Eva Tegnander in Norway, in Trondheim. Their sonographers are doing the scan, and if there is an abnormality, senior colleague is invited to have a look at the case. So they started first period of time, 18% detection without systematic approach. Then they were obliged to document every time a four-chamber view, detection rate 26%, and then they came and then said, now we want to include the outflow tracks on 2D. They had 40%, and they were disappointed. They wanted to increase. They have better number today because they're using color Doppler, and people are trained. But you see that you can increase detection by including more planes and teaching people what to see. So this is why many years ago we said it is time to write guidelines. And you know, when you write guidelines, you have always two groups of people. So the one who think what we do as experts should be standard. Come on, guys, we should do this and this and this. And I said, no, but it should be for the whole world. And we said, okay, we agreed in the first version that the basic examination should include the four-chamber view, and, you know, in a way, where technically feasible, and you can have a look of it. So in other words, you are not obliged, but we are encouraging you to do it. So this is where This is what we wrote at that time. If technically feasible, views of the should be attempted. In other words, if there is something missed, we attempted it, but it was not in a good position to be seen. So it is because one group say, I want to have the highest level. The other group say, be careful. The lawyer can take your guidelines and sue anyone. So this is why let's write it in a way it is a lawyer compatible way. So, but later on, with the new study, I will show you something different, and we decided to have another approach. And if you look at all data I put together in this slide, in summary, you will see that roughly, and you can go for your region and for your place. If you have a no target exam, different centers, not a specialized team, you have not more than 10%. I say sometimes these are the defects the patient will see. If you have magnified image, oh my God, the heart is so large. Yeah, I'm sorry, there is an Epstein. So you don't need to, if you are blind, you will see it. So this is something accidentally detected, or severe arrhythmia, and there is an AV block. So if you have places where routinely the four-chamber view, the patient does not leave the place until you have a four-chamber view, then the person are trained, and you may detect until 40%. Why not more? I will show you this later on. And you can have an extended exam, special center, four-chamber view grade vessels. We can reach 80%. Of course, Dario and Julien say, come on, 80% major, you will have almost 100%. Yes, but you know, in the middle, there are some defects we may not see because they are not either not detectable or not yet detectable, because some do it at 18 weeks, or not all people, even if they do this, are, let's say, able to have to detect them. So it should be roughly the number that you have, the 10, 40, 80% detection rate. And I hope that all of you are in the lower part and say, no, 80% is not enough. I'm not working on the Pareto principle. I want to have more than 80%. So, and these are typical anomalies we can see today in the four-chamber view. And you see today during our meeting, we'll have most of the cardiac anomalies will be covered. I say most because we cannot cover within 1.5 days all possible anomalies, and you'll hear us speaking today and tomorrow on the different conditions. Many years ago, this is me when you are laughing. Why are you laughing? What? So I wrote an editorial for the White Journal on why the four-chamber view seems to fail in screening, and gave some ideas, suggestions to improve detection rates. At that time, you were asked to write an editorial. Do you have an idea? I said, I write this idea. And I said, well, the reason one is what I saw in my surroundings, that neighborhood, the non-examined heart is defined as normal. So they look and said, oh, it's going to be normal. So this is the heart here, and then they said, oh, it's normal, and this is the heart. They said it's normal, but if you need to have a four-chamber view, and this heart, you see there's something echogenic. If you wait a little bit and you get this view, you see it's abnormal. So this is one approach, but in the meantime, this is almost has disappeared, because many centers working, they need to put images on their documentation system, and when you look at the images, they have to store at least one picture of the four-chamber view. So, but if you don't, you are not obliged to have to store a picture, then they will tell you, but I saw it, I swear it was normal. So the reason too, this is the major problem we have, and this is something we will focus on during our talk today, is there are four chambers seen, but the abnormality does not recognize, either because the image is not magnified, and this is something you can work on with the quality control. In the meantime, people understood that there is magnification, also because of the nuclear translucency screening, because there we learn to use the cine loop, to use the magnification, and this is something when you go to a place or you have some referral doctors, please go there to their center and train them. Because when I see images, I give them full course. I come around in the afternoon, I show them, if you see the heart, please put this button. It is zoom, magnify, and this is the picture, because you see on the screen, you see all the details. So magnification is something simply done. And the abnormality is not known, because they see the four chambers, but they don't see what is going on there. And let's say I give you 2 slides on this. There are findings which are obvious. I told you the word patient will see the abnormality. So Epstein lights at such a large heart, and this echogenicity, what is this ball, this tennis ball, this is a rhabdomyoma. But there are also anomalies where obviously there are no 4 chambers. You have here two atria with the ventricle. You have your hypoplastic left heart. You have your hypoplastic left heart where you see obviously that there are no chambers. These are detectable. Remember, both in the Ball study and the German study, 2/3 of the cases were detected. But why is 1/3 not detected? Because the fourth chamber view is less sensitive because the heart presents with 4 chambers. And this is why, in this case, you can count 4 chambers. And if the image is not magnified and the feet is not in good position, they will see 4 chambers. The same here, especially for the hypoplastic right heart, because we know that the right ventricle is slightly smaller than the left. How smaller is very small. So it can be tricuspid atresia, it can be pulmonary atresia with intact septum, or in coarctation, the ventricular disproportion. People learn to see the 4-chamber view, but they are not taught to understand that the size should be also similar and not disproportionate. And the same with the AV canal we discussed later on. This is why we emphasize that, please, the 4-chamber view should not be a chamber counting, but understanding how the abnormality looks like. So it's not only important to tell the people, do the 4-chamber view, but teach them how to recognize. So it is easier in a setting like a unit where sonographers are working because you can do teaching, but it's very difficult in a wide range screening where normal doctors are doing the scan on their own. So they say, you have to understand how the AV canal looks like, because in general they don't come to meetings. They go to meeting where, let's say, there is drug industry supporting, they have nice funny, expensive meetings, but ultrasound is boring because after the 3rd talk they fall asleep. And also we are also responsible for this. The third reason is the heart defect can develop in utero, and this is why it's not accurate to detect. So, for example, this is a hypoplastic left heart for 21 weeks, and this is how it appeared at 25 weeks. I could show you a lot of other images, but this, if it was not magnified, it will not be recognized, but later on it happens. So I receive once a year, at least at a meeting, a question from some colleague, is it possible, I saw the heart was normal, but then the child was born having hypoplastic left heart. Yeah, it's possible. We know this, it's what described since the 90s, and this is something you should know. And the same here in this condition. This is cardiomegaly at 36 weeks. So my God, how have we missed this? In the meantime, we know that this is pulmonary atresia with intact septum, and this ergogenicity. If you look at the video, you will have seen the heart is not, the right ventricle is not contracting. And this evolves with the tricuspid regurgitation leading to cardiomegaly. So this can evolve in utero. This is why it's always worth, when you have a look to a patient, always to have a look in 3rd trimester if you have a patient scan. So don't say, I've seen the heart at 20 weeks, I don't need to see it again. If you have the patient coming back for IOGR, for Doppler, for anything, look at the heart again. You'll be surprised to find occasionally muscular VSTs, pulmonary stenosis, aortic stenosis, or valve regurgitation, or rhabdomyomas, late detectable abnormalities. And the 4th reason is because it cannot be seen without color Doppler, muscular VST, or other things, and especially because you're using the wrong test. So it's like saying, I want to analyze AFP for screening for, for cardiac anomalies. You are using the wrong test. The 4-chamber view is for anomalies of the 4-chamber view, and you cannot expect to detect anomalies of the great vessels. So this is here cardiac anomaly where with color Doppler, with the proper setting, you see the flow over the midline. Could be difficult to see here at 18 weeks, the abnormalities of the 4-chamber view. Or in this condition, you see the 4-chamber view is nicely presented. It's a normal 4-chamber view, absolutely. And going to the great vessel, you see the transposition of the great artery. So this is another reason. So if you are still stuck to the 4-chamber view, you should know how to solve the problem, why anomalies are missed. And this is why today these are some anomalies having normal 4-chamber view. And this is why there are reasons why guidelines should be changed to include all over the world the great vessels in addition to the 4-chamber view. Now, there are some classical indications, like many things in ultrasound, what are the cases should be referred as a high risk. This is the classical one, diabetes and phenylketonuria. In my whole life, I had 3 patients with phenylketonuria. It's written here. But diabetes should be the over-diabetes because the pre-gestational diabetes. Parvovirus B19, I will today add, let's say, cytomegalovirus and so on. Rubella. I saw once in my life rubella with pericardial effusion. So, but we still have them here. Retinoids, all patients will never come to me. They will terminate just at 8 weeks gestation. So anyway, but the most teratogenic exposure is anticonvulsive. So we have here 3 times, but we should put them all together: valproate, carbamazepine, and phenytoin. Anyway, important is at the end is the yield, and these are the interesting one, the fetal indication. If you have any major cardiac anomaly, if you have thickened nuchal, if you have ductus venosus reverse flow, but the most common one are the extracardiac anomaly should be referred. So indications may be interesting, but in general it will not work. In Germany, we have a longer list of indication, adding also the function. Not the function because we analyze cardiac function, but conditions where the function can play also a role, like twin-twin transfusion syndrome. If you have monochorionic pregnancies, we refer them because with the heart, you'll analyze if there is an insufficiency, and then you detect the cardiac problem. It's not always about cardiac anomaly. The same with the maternal anti-Ro antibodies. It's not about cardiac, let's say, defect, but it's more about cardiac disease. And this is why all over the world you'll find this scheme, high risk are referred to a specialized center, but the screening policy will only when there is something suspicious refer there. So it sounds good, but it will not work this way. This is why the title of my talk was supposed to be Screening versus Fetal Echo. In screening, we are asking mainly for the 4-chamber view. Fetal echo is more comprehensive. We'll have here the upper abdomen, the 4-chamber view, the 5-chamber view, the short axis, the 3-vessel trachea view, and if feasible, also an aortic arc. We'll add color Doppler to see all the details. But you have noticed, all of you, that all over years, there is a shift from the simple 4-chamber view to include a little bit more. And this is what we are encouraging people to do. And this is what we even using color Doppler. And this is now the recent version is six years old, where we decided to have these, at least these planes, and Julien will discuss this. I tell you my personal idea about this. We should put more, and we are discussing now to have a new version. Why? Because as an ESWOG, we are not locally related to any person. If you are in your local society, in Germany, I can say, you know, I cannot add this and this and this because no one will accept. But as an ESWOG, you can say anything because there is no country where you say, you know, someone will sue you because international ESWOG is telling you have to use the color Doppler. In the US, when you use color Doppler, they tell you, oh, but this is, you have to charge another rate from the insurance company. This is why if you use color Doppler, it is a complete echo, and there is a rate which is higher than doing the screening. So, you know, but you can have an approach as you want. And my personal vision is to have it very comprehensive as a basic screening in a way, and each country can take out of it for its local part what they want to, and then can have an increase. Because we cannot consider all countries of the world to say, let's go lower to the 4-chamber view. I prefer to go a little bit higher level and then be more provocative. Instead of standard of care should not be low as an ESWOG, should be higher. So, how to improve detection? This is a question we can ask ourselves. It should be training, it should be with logbook and so on. And training can be frontal teaching, like you are sitting here. And because of data privacy, I had to show the heads from behind and not from the front. So, and it can be live scanning, ideally hands-on. Every place I go in the world, every place, there is no single person interested in having his hand or her hand moved. They always all want to see an expert scanning. Ask Dario, ask Giulini. They never sit and say, please show me how to get, because the other one said, oh my God, she's sitting here, she cannot scan, she needs someone to teach her. So this is why they will watch, and then they learn at the end, oh, he can scan very well. I wish I can do the same. Or they are very happy the baby is not in good position, and then when I turn the baby, oh, the baby turned, he's lucky. So, but you know, the trick is how to turn the baby and not to be lucky. There is also learning on volumes, which is also a very good approach. This was in India, having course on let's say, volumes, which is a good view. What we're doing is you present volume. People do not know what kind of anomaly it is. They have to scroll in the volume and to guess. And once we have the result, we discuss this condition. And we went to the next anomaly. Easy for Epstein, more difficult for right aortic arc, for example. And there is also possibility of simulation here from the World Congress. Jihad Shalouhi showing how to move, and you have a volume inside. And the most recent one is the virtual reality done by Marcin Vicic here in Berlin last summer. And then you have this glass, and you can approach. And so we can invite him one of these meetings to show. And this is a way you can let's navigate within the volume and have a look to the 4-chamber view, but also select some anomalies or guess what are the anomalies. And then, yeah. So how to scan? This is something very interesting. In general, I teach people when I go to a theoretical course, not on the cardiac anomalies, but on scanning. There are 3 things you should know. You should know the transducer, you should know the image, how it should be optimized, and how to put the display. And these are things to consider. We discussed this in ISWAC, the gestation age, the high frequency transducer, the highest you can, and magnify the image and use the cine loop. And people, when you watch someone scanning, you know after 1 minute if this person can scan or not. Some are stuck to a place, and they are waiting that the baby shows the right hand and the left hand and the heart and the face. But you need to move, and this is why you should teach people how to move the transducer and to tilt it to get a view behind the ribs. If there are ribs inside, you can go from the apical approach and get it. So this is here the simple teaching. You have this position, you go with the probe. Let's say second trimester easy, first trimester no way. You need to wait the baby to turn. So you go this way on the belly, and then you move this way, and you magnify the image. And once you see it like this, you magnify the image. And then once you have this image, there are 3 parts I told you: the choice of the transducer, the architecture of the image, which means try to fill the picture with the thorax, with the heart. Then you have appropriate image. Not only the heart, but you should see the surroundings. And then know what are the presets you can do here. Color Doppler is going to be very important, and Dario is giving a talk only on color Doppler. He will show you what are the things you should consider, but please try to have the best color Doppler image, because this is the key to work on, to make the good diagnosis. You may not need to have Doppler of each valve. We don't do it on routine. We do it in selected cases, in high-risk cases. If I have a previous case of an aortic stenosis in the patient, I will scan the aortic valve, but I don't do it on routine. Unless I have some aliasing over a valve, I will do it, or sometimes to document things. So, because you can get all regions, Dopplers, but we have reference ranges, but this is something we agreed on. We don't do it routinely in the consensus paper. So again, what is the other way? What is also important is you should do some supervision, and very important, if you are running a unit, do an audit. The audit you will find out how many cases were missed, who missed the case. In one Danish study, they analyzed the time when the cases were missed. If they found out that 50% were missed half an hour before lunch, that means they changed the lunch. This is, there is a chronobiology. You have hypoglycemia, or just after lunch, you will see yourself, I will wake you up, the one who sleeps after lunch. There are times where you need some to stand up and do some sport. And this is a recent study published by Hautala from Finland in the British Journal, showing how they implemented the 3-vessel trachea view in their screening strategies. They train sonographers in a way to say, we have goals, theoretical course, then the clinical training in one experienced person, under supervision to scan 50 patients and send 10 with abnormalities. And they had at the end to finish 150 pregnancies on their own and to have a logbook with these cases. And then they have a certification exam, and every second year they have a theoretical education and minimum of 500 per year. So they have a standard, and they show that they had an increase in detection rate of great vessel anomalies. This is perfect, because you don't tell people, from tomorrow on, I heard at the meeting in London, you have to get the 3-vessel view, now you do it. So it will not work. Ask people to have images, and not what we do with Kipros, to send the best 3 images of the nucle, but consecutive. Or what the French do is you ask for numbers. You say, I want to see the patient number 3 in January, and so on. And then if you select, you'll see how bad our image is. Sometimes, honestly, when I'm scanning and I don't get the proper nucle, I measure something and I say, Kipros, I hope you are not watching me now. And I hear him say, yes, Shawi, what are you doing now? But there are exceptions, but it should be the exception, not the rule. I want to come to the end, and this is also a very nice study published by Monique Haas in the Netherlands. They analyzed images of cases which were detected and undetected. And they found out that the quality of the plane is the most important to make the diagnosis so. And the more cases, or let's say number the sonographer is scanning, the higher is the quality. So if you know that the experienced sonographer doing a lot, I've seen a lot, disappointingly that 30% were clearly visible but not recognized. This is something you say, oh my God, look, it looks like a transposition. There is one vessel, why have you not seen it? It looks like an hypoplastic left heart, they have not seen it. So this is true life. And these are the inevitable ones. So these are numbers I think could be representative for a unit where several people are working, where sonographers are doing the job and so on, not very high-risk people. So my message to you today is this one. We started by this point, and I think there is no clear cut between what is screening, what is fetal echo. Rather, I think, and this is what I hope my co-chair think as well, today is screening rather looking to the heart completely and saying this is normal, but this is definitely abnormal. And the fetal echo is really spending time on making the diagnosis, and in high-risk patients as well. So we cannot tell people do less work, because if they do less work, we'll never get the cases detected. So many of us are doing also screening on so-called high-risk, which are not true high-risk. I have 2 slides. So challenges today is, the first one is not a challenge anymore. Today is, if you see an abnormal heart, what is the differential diagnosis? What is the spectrum within one cardiac anomaly? We used to know hypoplastic left heart, but you have one with no chamber, one with a small chamber. What is the genetic etiology? How to counsel the patient? How to tell them about the prognosis? Not the prognosis in the book, but your own prognosis in your city or in your country, because it can be completely different. And people ask me how to become a specialist in fetal echo. Learn the basic and advanced anatomy invariants. Learn how to adjust your high-resolution machine, because the machine is the most important part of your work. Be open for new technologies and published science, you know, the three-vessel view and so on. Seek for one detail, because it can be the hint for the diagnosis, like the confluent vein in abnormal pulmonary venous drainage, or adapt observation in postnatal study into fetal images. This is what we learn from articles in pediatric cardiologies. Try to put different symptoms to find the syndrome, and read the White Journal and other journals. And also read the books the 3 speakers wrote. And should I give you a discount for, yeah, for, no, but the most important part, this is what I ask people. If you find a cardiac anomaly, you say it looks abnormal, you have 1 to suspicions, go to the books, read in several books, and ask the reader to come back. Or if you send to some expert and it's a tetralogy of follow with this and this, or pulmonary atresia with MAPGAS, and so on, you have to read in the book, then you know it. And if you want to be better, give a talk on it for your nurses. And then once you speak on it, you will remember it. And at the end, you have the most common 20, 30 anomalies one of these days done. And train your memory for deja vu. So I will finish with this slide. If you are running a unit where you do fetal echo, you will end up having close cooperation between cardiologists and fetal medicine specialists. You will need also a good referring physician, because these are the source of your good cases. And last but not least, you'll have a good cardiac surgeon to discuss with, and you have a lot of people working around the parent support, midwife, nurses, psychologists, geneticists, and so on. Because without this, there is no way to advance in a unit. Thank you very much. I hope it was a slight, small warm-up, and we start now with the day. Thank you.